Okay, thank you. So good morning, everybody. My name is Nicola Cognin. I'm currently a PhD candidate at the Technical University of Darmstadt under the supervision of Professor Marco Durant, who's also leading the biophysics department at GSI. And what follows, I'd like to give you a brief overview on the current state of agent-based modeling of radiation-induced lung fibrosis, which is the main focus of my PhD project. First of all, what is radiotherapy? As you may already know, it is a treatment which is used in cancer care, and it involves use of ionizing radiation, such as photon beams, ions, charged and uncharged particles, as a tool to sterilize cancers. It's used in cancer care, and nowadays is integrated in more than 50% of the therapies of new cancer patients. But normal tissue toxicity limits the lethal doses that can be delivered to the tumors, both in terms of irradiated volume and radiation dose. And as you can see from this figure here, as the radiation dose increases, both the normal tissue damage probability and the tumor control probability increase. Therefore, constraints must be set in order to maintain acceptable levels of toxicity on radiation dose and irradiated volume. For my project in particular, I focus on the specific radiation-induced injury, which is the radiation-induced lung injury or RILI. Just let's have a brief look at the mechanisms. First of all, radiation interacts with the pulmonary tissue, whose targets are mainly alveolar epithelial cells, and then can directly or indirectly damage the cells by means of DNA double-strand breaks or by the production of reactive oxygen species that can later on further spread damage. And DNA damage can also stimulate the production of ROS by these cells. When these damaged or senescent cells are damaged, they immediately initiate signaling processes, which are mediated by the release of extracellular mediators, such as cytokines and chemokines. The immune system is then stimulated to recruit inflammatory cells, and the inflammation causes radiation pneumonitis. If this inflammation is persistent, it further induces damage to the cells, which react, releasing new factors that can drive the proliferation of fibroblasts that later on differentiate into myofibroblasts, taking place in the so-called remodeling phase, in which they release huge amount of extracellular matrix that can eventually lead to decreased lung compliance, to disrupted gas exchange, and ultimately respiratory failure and death. So why is it so important to understand and modulate RILI? First of all, the mortality of lung and breast malignancies is still the highest among cancer deaths. And the onset of RILI in patients which undergo thoracic irradiation is relatively common. On top of that, fibrosis, which is the main late side induced by chest irradiation, is not limited to the lungs, and therefore a comprehensive model of RILI will also be suitable for other uses. And last but not least, a RILI model could also be tailored to a COVID-19 disease progression model, as it was reported that the inflammatory responses are at the core of the diseases. This is mainly due to the fact that the ACE2 receptors are mainly presented by the epithelial cells, which, as I said before, are also the main targets of the radiation. So at the moment, the problem is that there are no mechanistic models of normal tissue toxicities. One would ideally expect these models to predict normal tissue complication probability and to play a role for the treatment plans which aim at escalating the tumor dose. What we have right now are phenomenological models, but these models rely on input data of tolerance doses for the organs at risk, which are derived from clinical experience. Just to give you some perspective, this here is the LKB model, one of the most known. And it's just to give you some perspective, as I said, it is assumed that the probability here that the complication inducing threshold dose X follows a probit distribution, and the normal tissue complication probability is just computed by using the cumulative function. And it also allows to take into account heterogeneous irradiation to the organ. So what is used here is not actually the dose, but this is the equivalent uniform dose. But as you have noticed before, the adverse effects of the radiotherapy are often not limited in number, and the path that leads from ionizing radiation to cell death and tissue damage is not straightforward. So in this context, mathematical and computational models can provide valuable insights that can be useful for tuning the radiotherapy parameters. And the use of these models in biomedical frameworks as a well-defined pattern, which I'm sure you already know, as you are experts on. I'm skipping this. Okay, this one is the only mechanistic approach that I was able to find in the literature. Just to give you an example, here the authors model the normal tissue complication probability using the concept of functional subunits, which are basically tissue volumes that can be fully regenerated starting from a single stem cell, a surviving stem cell. And so to inactivate an entire functional subunit, one has to kill all the stem cells. And the surviving fraction of the stem cells follow Poisson statistics that relies only on the given dose. And given that the lungs are considered parallel organs, it is assumed that they stop working properly when a certain amount of functional subunits is inactivated. But you can already notice that this oversimplifies the mechanisms that we showed before, as it lacks inflammation-induced tissue damage modeling. And moreover, this kind of modeling lacks a description of the time course of the disease, which is particularly important to determine the fate of the patient. So to overcome these shortcomings, we propose the use of agent-based modeling to replicate the complex network interactions taking place after the irradiation of the tissue. And to do so, we're using Biodynamo, which at this point of the presentation, you all already know well. So our idea was to start off by simulating the agents and their simulation space. So reproducing a geometrical structure of the lung or part of the lungs, and then define the behaviors of these cells. So at the beginning, what we wanted to do was to reproduce the onset of the idiopathic pulmonary fibrosis, which very well resembles the radiation-induced, many of the mechanisms of the radiation-induced lung injury. So the idea was to take a mathematical model which works with differential equations and transform this model into an agent-based model, giving agents behaviors. And both these aspects, we wanted to model both these aspects using Biodynamo. On top of that, we wanted to simulate the damage to the cells that can then either undergo apoptosis or become activated using as an input cell survival curves as a function of the dose, like this one that you can see here. And these two phenomena, the apoptosis or activation of the cells, are the ones that triggers the onset of the pneumonia and later on of the lung fibrosis. So what we did was we started modeling the geometrical framework, and what you see here actually is not the one that I'm using right now, but nevertheless I wanted to show you what can be achieved using Biodynamo. And these structures are available and working. And very briefly, the airways of the lungs can be distinguished between conducting, which are the ones that transport the oxygen from the outside into the lungs, and the acinar airways, which are the places where the actual gas-blood exchange happens. So the functional unit of the acinar airways is the acinus, which is made up of cylindrical structures, these alveolar ducts, and they are arranged in a tree-like fashion and covered with alveoli, where, as I said before, the alveolar epithelial cells of type 2 resides, which are the main targets of the radiation. And so basically I put together multiple alveoli to get these cylindrical structures, and then with multiple alveoli, I assemble the acinus. Despite the beauty of the previous structures, what I'm currently using right now are the structures here in gray on the right. Here, the shape of the acinus is still the same. So for each father node, two branches originate with a random azimuthal and polar angle. But instead of being a cell, now the agents represents alveolar ducts or segments. So we basically decided to lose a little resolution due to a few reasons. So first of all, to reproduce a bigger portion of the lungs with fewer agents. Also to match the results of this paper, where basically they show from a relation between the radiosensitivity of the cells and the number of stem cells. This led to the understanding that actually the size of the functional subunits of the lung is slightly bigger than the alveolus, so this could actually match the size of an alveolar duct. And finally, Also, we are simulating, as you can see, are almost 10 different substances which are diffusing and sometimes also interacting among themselves. So we noticed that better results could be achieved by reducing the integration time constant. So having a simpler model of this type also allowed to speed up the simulation time. So given that our agents are velar segments or dots, they have properties such as the initial and the current number of cells that can also be updated, set, and get. And for each of them, we defined multiple behaviors such as secretion, apoptosis, proliferation, differentiation, and activation for all the cell types that you can see here. So what happens at every time step is that each agent performs all these behaviors that will finally result in the increment or decrement in the number of cells that it represents, let's say, but also in changes in the concentration of a substance in the location where it resides. So a goal of this project, this agent-based modeling, could be the reproduction of the fibrosis index, just to get an idea of how well the model is performing. And the authors of this paper showed that the fibrosis index curve, the fibrosis index is shown to be a very good surrogate of lung fibrosis. So it can be calculated using parameters that can be measured by CT scan, such as the increase in the density of the tissue due to the accumulation of the ECM and the decrease in the volume of the lungs. And they also provided this equation which relates the fibrosis index with the dose. And now some results. So we started off modeling homeostasis. So as mentioned before, really shares many mechanisms with idiopathic pulmonary fibrosis. And since the latter has been well characterized, we used the results from a mathematical model of idiopathic pulmonary fibrosis, the one which I already shown before, as a benchmark for my model's results. So first of all, I wanted my model to simulate, to replicate the homeostasis, this given the initial values for the concentration of the substances from the mathematical model of IPF and the initial number of cells per avellus from the literature. I wanted my model to reach a steady state and maintain it. So I had to alter and tune all the secretion, proliferation, differentiation, and apoptosis parameters. The readouts of the simulations are the number of cells of each cell type and the average concentration of each substance. And keep in mind that for the average concentration, I'm actually using the agents as probes. This means that the concentration that you see plotted in the next slides is the average of the concentration measured by each agent. So I'm doing so since what matters is actually the concentration that the agents perceive, as many behavior rates depend on substance concentration, local substance concentration. So what you see here is a number of cells per avellus for a simulated time frame of 30 days, and the experimental data are in blue, while big bands are used to show threshold, 10% threshold, and you can see that the values never exceeded this 10% threshold. And also use this relation here, this formula, to compute the relative change at each time step, and you can see that they never exceed the 0.025%, which is quite low. And the same is true for the substances concentration, which, as I said before, are many. I want to stress that these substances are not only diffusing, they are also interacting among the cells. So again, they reach a steady state quite quickly, and they never exceed the 10% threshold. That again, I computed the relative concentration change for each of them, and you can again see that there's always below the 0.025% threshold. So we can see that the model can simulate homeostatic conditions. Now, at this point, we can introduce some damage, again, with the idea of reproducing the results from the IPF mathematical model. And this slide, you can see multiple curves where each color corresponds to damage levels. And since in the mathematical model, the authors used the concentration of the cells instead of their number, what we looked for here was to qualitatively reproduce their data. So the blue lines here show that what happens when the damage is approximately the same as the one used by the authors of the other paper. And you should see that our model can qualitatively reproduce the curves in the lower part of the slide, these ones. We also added this intermediate damage state, which will be particularly important when simulating really. And we also added the alveolar epithelial cells of type 1. And you can see that as the damage increases, the population of alveolar epithelial cells of type 2 is not able to maintain this one. Also keep in mind that alveolar macrophages in our model are represented by M2, while interstitial macrophages are M1 in the IPF mathematical model. The same applies for the concentration of the substances, for which we can see both qualitative and quantitative matches. Again, if we focus on the blue lines, we even added two additional extracellular mediators to make them all more realistic, which are FGF2 and the inactive state of TGF beta. It's important to notice that for damage percentages higher than 40, the AEC2 population is so depleted that it cannot sustain the fibroblast population. So this leads to a decrease, you can see here, in the final concentration of the extracellular matrix. Lower concentration of extracellular matrix normally are associated with lower fibrosis grade. And we know that this is not true, but it's also still interesting to see what happens as this was not reproduced in the laboratory. And finally, now that we know that our model can replicate the onset of idiopathic pulmonary fibrosis, we can actually start modeling the onset of ReLIM. In particular, a few mechanisms that characterize ReLIM haven't been modeled for the IPF, such as the alveolar epithelial slag 2 hyperplasia following radiation-induced damage, which was also observed for radon-induced lung damage, and the bystander-induced senescence of the AEC2, which seems to have a pivotal role for spreading the damage towards healthy cells. So what I'm doing now is trying to model these two new key mechanisms and to see how well the model can recapitulate laboratory results. I'm using the ECM density distribution changings that you can see here, which is also used in the clinics. So basically, these histograms show the distribution of the extracellular matrix within the simulation space. And the voxels are the cubes that define the diffusion grid. So they are used to determine the amount of volume. So after a simulated time frame of 300 days or 43 weeks, this is what we observe. So again, we can see that there is a right shift. But again, this trend is reversed for percentages higher than 40, 50. And just for comparison, on the left, you can see experimental results, data from mice, which were treated with radiotherapy. Again, you can see that also here they observed this right shift in the distribution of the extracellular matrix. Actually, they use the ounce-field units CT values, but can be related to the ACM concentration. So now the next step will be to simulate these results. And that's it from my side. Thank you for your attention, and I'm happy to take questions.
Thank you, Nicolo. So who would like to ask a question? Again, please, you can also just interrupt me, actually. So if you have a question, and then we can ask Nicolo.
Hi, Nicolo, this is Toby. Sorry, I didn't find the raise hand button, so I'm just going for it like this. I wonder if you can tell me what kind of simulation time step you use, because it's all like you're simulating for 43 weeks or something. So just wonder what is the time step that you use to actually simulate this kind of long time span?
It took like 12 hours, if I'm not wrong, to simulate 300 days.
Mm-hmm. But also, in which kind of like, what is the time step that you update the model with? Like, is like one time step, does it correspond to a day, or is it like a minute, or is it an hour?
Yeah, I'm sorry. It's 1/10 of a second.
Okay, that is very detailed.
Yeah.
Cool. Thank you.
Thank you.